Hello, I'm Thomas Stoney. I'm a paramedic here at Orange County EMS. Today we're going to be talking about video laryngoscopy using our Airtraq device. So we're going to be using this video laryngoscope whenever we're intubating a patient, likely in cardiac arrest, respiratory arrest, or any other kind of pathology that will need to secure a patient's airway. So first and foremost, what I would recommend doing is we're going to take our Airtraq blade, a size that's appropriate for the patient. We're going to take this out and we're going to prep this blade first. And the reason why I'm saying this is because as you see this orange light here at the bottom of our blade, whenever we press it, this is going to activate our light at the end of our blade. This is going to be useful because it's going to heat up the channel to allow for easier passing of the tube. Also, we're going to remove this video eyepiece here, as this can be used for manual insertion or direct vision. So as this is heating up, we're going to place this here to the side. We're going to prep the rest of our equipment. Then we can take out our airway head, and then whenever we plug this into our blade, this will automatically turn on. So we're going to sit this to the side as well. Then what we're going to do is we're going to prep our endotracheal tube, and again, a size appropriate for the patient. So screwing on our syringe here to the blade, this takes approximately 10 cc's of air. So we're going to prep this balloon. So after we inflate it with approximately 10 cc's of air, we're going to visualize there's no cracks, leaks, or damage to the tube. We're going to deflate our tube. What I like to do is I like to keep this attached to the endotracheal tube so that when we do pass the tube, we can just easily inflate it. So now I'm going to take my Airtraq head and I'm going to plug it into my blade. And as you see here, this is going to automatically turn on with the button behind. See here is this is what we're looking at here on our face with our Airtraq. So one thing to keep in mind, this is not intubating using direct laryngoscopy. We're not taking our laryngoscope and cranking upward and backward. This is a pretty delicate procedure. What I like to call is using a wine glass technique by taking 2 fingers and a thumb and simply using this to lift forward and back. And so as you can see here, we can visualize our cords. So we're going to take a snapshot by just simply pressing on the screen, and now we can go in to pass our tube. So our tube flows in well, and as you see here, my black line has just passed the cords. So after this, now I can simply disconnect my tube and remove my blade. And then we're going to follow our securing techniques and our confirmation techniques as stated forward. Ensure that you're taking your endotracheal tube and you're placing it into the channel of the blade. So what we're going to do is we're going to lubricate it first, and we're going to take our ET tube and actually slide it in through this channel here. And whenever you put it in the blade, you want to ensure that the actual bevel piece is not going to extend past the bottom of your blade here. After you've done that, now you can advance for your attempt for your endotracheal tube placement. So again, we're going to take our patient, place them in a head tilt chin lift, earlobe in line with sternal notch. We're going to take our device and we're going to come in parallel to the patient's mouth. So we're going to enter in past the teeth, and what I like to do is I like to advance slowly and visualize each piece of anatomy as I approach. As I'm passing in through the base of the tongue, I can see my epiglottis. I'm going to place my video laryngoscope's blade into the vallecula, and now I'm going to take a picture of the actual cords, and I'm going to come in for the advancement of the endotracheal tube. If you find yourself getting hung up on the rungs of the vocal cords, what you can do is you actually rotate the endotracheal tube, and that should allow for an easier pass. After you've passed the tube through the cords, you're going to take another picture here, and you're going to remove your tube from your channel and inflate your tube. You're inflating it again with approximately 10 cc's of air, and after you've done that, we're going to place on our end-tidal capnography, our BVM to ventilate. We're going to see condensation in the tube. We're going to auscultate all fields of lung sounds, auscultate for absent epigastric sounds, and after we've confirmed placement of the tube, now we can use our commercial securing device, like our Thomas ET tube holder, and secure the endotracheal tube. Ensure that you're logging wear out on the teeth that you've actually placed the tube. So right here I'm at 19 on the teeth, and I can document it accordingly. Also ensure that whenever you're passing the tube through the vocal cords, there's a black line on the tube. The tube is only to insert just past the cords with that black line. You don't need to advance any further. If you have absent lung sounds on either side of the lungs, you can withdraw the tube and then reconfirm that you're in your placement. That is the video laryngoscope. Thank you.